Wow. Good morning, Nargisa.
Good morning. Just 1 second, I have to.
Do you have your background?
Not yet, 1 second. Mhm.
Good day, Jamil.
Hello, Nargisa.
Good afternoon.
Good afternoon. Good afternoon, Nargisa. Nice to see you.
Me too. Nice to meet you. I'm so glad. Today we will have discussion and we have small changes. Unfortunately, Dr. Artur Ayalo, he has emergency surgery, so he couldn't make it. But we have two more moderators from Bangladesh, from the General Secretary of Bangladesh Society of Neurosurgeons. So I will introduce.
Sounds good. Sounds good. And Professor Bennett.
Hey, how you doing today? Welcome.
Good morning. Good morning.
Thank you for participating.
I'm sure good morning for you, or this depend. It's depending on where you are. Now you are in US, yeah?
Yeah, 7 o'clock in the morning now.
Cool.
Which is late.
I think in Mexico it's too early too.
Yeah, it's 6 o'clock. It's 1 hour earlier.
Wow,
So,
6 o'clock.
yeah.
Now in Novosibirsk almost 7.
Well, in neurosurgery, that is not early. That's late in neurosurgery.
John, could you make me co-host, please? I have to put people to banner.
I need the banner on your background.
Put me a co-host and I'll put the banner, please.
What was the deal?
Yes.
They're making demands now. Wow. What happened?
Just 1 second.
What am I trying to do? Oh, I'm trying to get another.
Yes, or could you make Dr. Sumon run as a panelist, please? He's our moderator.
Okay. Make you co-host, and you can do that.
Okay.
Okay. Okay, we're starting in about 4 minutes.
Yes, in just 1 second.
You can't figure out the background?
Okay, 1 second.
It's very easy. It's very easy.
Так, Rania Galyamova is our speaker today. So, done. Abiram, okay. Great.
Hi, Nagisa. Good evening.
Welcome.
Hello.
Welcome.
Hello.
Happy Diwali to you all.
Happy Diwali, Dr. Abiram. Today is a very, very big holiday in India, and not only in India, I think.
Hi, Nargija. How are you?
Hello, Dr. Sumon. I'm fine. Thank you. Thank you for joining.
Thank you for inviting us.
Thank you. Is Professor is going to join?
Yeah.
Okay, great.
Sir is going to join. Hi, John. How are you?
Hey, so welcome. Thank you for participating.
Thank you for inviting us.
We're starting in a few minutes. as soon as Nargiza gets her background on.
Yes, yes, 1 second. So many things. 1 second. Blur, choose my virtual background. Now you okay, John? Are you happy?
Yeah, I'm very happy.
Okay, great.
I didn't know they had beaches in Uzbekistan.
We don't have it.
Oh, Anton is here, okay. Okay, Anton's coming in.
Antonio, okay.
Is anybody else in the panel?
Just 1 second, I have to make Antonio Ivanov as a panelist. Great.
Hello, Nargiza.
Hello.
Welcome.
Hello, John Bennett.
Welcome. Thank you.
Thank you.
Anton, I'm trying to get you in, Anton. I don't know if you can hear me.
Yes.
Okay. Sometimes when you admit someone, they refuse to come in. Okay, 1 minute, Nargiza.
Okay.
So everyone's all set up. Anybody have any last minute questions about or want to test something in the presentation? We can have.
Can I try, please? Can I try, please?
Yes, please.
Yeah, we don't have to start on time. Let's address your issue.
Okay.
You're the first speaker, right, Jamil?
Yes.
What did you want to do, Jamil?
Can I go on?
Oh, okay, wait, we're starting now. 10,
I will
9.
introduce you.
Hold on, Nargiza. Hold on, Jamil. You have to get off the screen. Okay, let me.
Okay.
Yeah, get off. Okay, I'm going to take you off the screen, okay?
Can you hear me?
Dr.
Yes.
Jamil, 1 second. 1 second. We can hear you.
Wait
Just-
to share. Wait to share, okay? Wait.
Okay.
We have to introduce you, and we want to introduce your face. We don't want to introduce your presentation. Okay, 10, 9, 8, 7, 6, 5, 4, 3. Good morning. This is Dr. John Bennett from sunny Miami Beach, home of Neurosurgical TV. We have another well-organized webinar by Nargiza Sartova, Uzbekistan neurosurgeon, putting together a great cast of speakers today, and I'll turn it over directly to her. Welcome, Nargiza.
Good morning, good afternoon, good evening, everyone, dear listeners, colleagues, and professors. It's a great honor to be, the host on Russian Neurosurgery Grant Rounds. Today is our 5th webinar, and I'm glad to introduce our speakers and moderators. Let me just first introduce our moderators, Professor Shafiqul Islam, MD, PhD from Bangladesh, head of the Department of Neurosurgery in Dhaka Medical College Hospital, General Secretary of Bangladesh Society of Neurosurgery, well-known educator in southeastern countries. Also, I would like to introduce our second moderator is Dr. Shumon Rana, MD, Assistant Professor Neurosurgery at Dhaka Medical College Hospital, Fellowship in Endovascular Neurosurgery, Fellowship in Vascular Neurosurgery in Japan. And also one more moderator from India, Abhiram Gapita, MBBS in Kataji Medical College, MCH from SRMC Chennai. And right now, Dr. Abhiram is working in AIG Hospitals, Hyderabad, India. Let's go for our first speaker. Professor Dr. Jamil Rizaev, MD, PhD, Physician-in-Chief of Federal Neurosurgical Center in Novosibirsk, Siberia, graduated from Chelyabinsk Medical Academy, residency from Polenov Neurosurgical Institute in St. Petersburg. Dr. Jamil Rizaev is a member of a lot of societies, European Association of Neurosurgical Societies, SIBNeuro, North American Skull-Based Societies, Walter Dandy Neurosurgical Societies, also well-known educator in Siberia and in Russia, holding his position as a chief more than 10 years. And Dr. Jamil is organizer of a lot of international conferences. Today, Professor will be talking about vestibular schwannomas. Please, Professor, you are welcome.
Thank you very much. Thank you for kind invitation and kind introduction. And now I need to try to share my screen. Couple of seconds, please. It's okay?
Yes, we are waiting.
Could you?
Yes, now
Could
we
you
can.
see my screen?
Yes, we can.
Perfect.
Okay, thank you again. I thank the organizers for the opportunity to share my humble experience at this Zoom meeting, and the topic of vestibular schwannomas, or acoustic neuromas as they are also called, is a very extensive and very large. But my time is 30 minutes, and I will skip some general questions of epidemiology, terminology, history, clinical science, and MRI appearance, etc. And I will try to focus on the specific features of surgery in this area. But still, I have to say a few words about history, only a couple of words. More than 100 years ago, the two German pathologists, Dr. Henneberg and Dr. Max Koch, proposed the term cerebellopontine angle. And since then, surgery in this area has haunted and has encouraged many generations of neurosurgeons. There is a very good popular science book about the surgery of this interesting complex anatomical area, and I strongly suggest to my young colleagues to read this book. Very interesting. Indeed, it's a very small place, and most of pathologists that occur here are benign in nature. But as my colleague, distinguished professor from India, Kiki Turel, I am sure all of you know him, he aptly puts it, but this is malignant localization. And this is not a rare disease. This is a relatively common disease. About 10% of all intracranial tumors are acoustics. As I mentioned, this is a common disease. Approximately 200 patients are to be diagnosed each year from this huge territory. We get elective patients, including patients with acoustic from this huge territory, from Ural Mountains to Far East to Pacific coast of Russia. Of course, not all 250 patients reach our hospital, but a big part of them. About 25 million population, this low dense population, our hospital activity cover it, and 250 cases annually. We only focus on such patients with large and huge vestibular schwannomas, and routinely we use this classification by Majid Sami or Hanover classification, and one more classification we use routinely. In our hospital, we get patients just this large and giant. Probably patients with small tumors are admitted in other hospital, and to be frankly, this appears to the existing competition between radiotherapists, radiosurgeons, and conventional neurosurgeons. The treatment of relatively small tumors is very debatable, controversial, and I'll not waste time discussing this issue today because it's very specific and very debatable issue. We have 4 treatment options for patients with acoustics: observation, radiation, surgery. This main topic of my today talk, and a combination of that options I mentioned above. So the surgery of vestibular schwannomas, and total resection should be strived for. This is the ideal strategy, but to be honest, it must be said that there are no supporting data of high class of evidence on the frequency regrowth, the rate of development of regrowth, etc. Much of it relies on expert opinion. It must be remembered that any remnant of the tumor can lead to regrowth. But many questions on treatment tactics remain debatable, and few areas in our field, our professional field, have generated more intensive debate than surgery of acoustic, and in general the surgery of CP angle area. Principles of surgery have not changed for many decades, and you can see these main principles. At the stage of planning the surgery, we have to think about many important things, but the most important rule of surgery remains unchanged. Don't rush, don't be hurry, and haste makes waste. There are 3 main approaches for treatment of acoustics: middle fossa approach, translap approach. This translap approach, also called presigmoid approach or posterior petrosal approach, and retrosigmoid approach. In my routine work, I use retrosigmoid approach in treatment of acoustics. I prefer linear incision of dura mater because sewing is more convenient before finish surgery. And the arachnoid space can be quickly opened at any size of tumor. It not depend on size of tumor. And in case of huge size of tumor, it's not too hard to open arachnoid plane. I almost always, I open the meatus first. In my opinion, the removal of the tumor should begin from this stage, and I can explain why. Even the largest tumor size, for example, 5 or 6 centimeters, you can always easily find the area of the internal auditory canal. Only 5-7 millimeter below tentorium is point where you can start remove the dura and begin tumor. And when you find the facial nerve in the canal, you get a very important, excellent anatomical landmark. This is very important. And the second reason why I immediately drill off posterior wall of meatus before debulking. I know that few people write and talk about this, few my colleagues, but in my opinion, it should be said. It's just that early in the second half of the surgery, towards the end of the main stage, it's often just too lazy to do it. This frankly. I use cutting bar, Kerrison ranges, and diamond bore in sequence, and also sometimes I use sonopet. Removal of the intracranial fragment of the tumor allows finding the peripheral part of the seventh nerve, and this some intra-op pictures you can see the content of opened meatus. Here are some more pictures of intracranial contents after removal of meatus walls, and a couple of more, please. And reducing the volume makes a tightly seated tumor more mobile, but here we must be careful not to perforate. Just a moment, I start my video. Not to perforate the tumor through this surgical tool. For example, with tip of Cusa or other type of cavitron, because it's very dangerous. It's possible to damage the facial nerve on the ventral surface of the tumor. At this stage, I constantly use suction tube with monopolar probe stimulation to roughly determine the location of the nerve, especially on the ventral surface of the tumor. You can roughly navigate at what distance from the tip of the section is the facial nerve. And another important structure in this area is anterior inferior cerebellar artery. And short remind that ICA is divided into several segments, 4 segments, and it begins from basilar artery. And ICA does a loop relatively to internal auditory canal. And you can see intra-op picture, this loop of ICA. And ICA is located along the caudal and middle part of the tumor, and it will not be possible to achieve the lateral surface of the upper part of medulla oblongata and the lower nerve part of pons and lower nerves without separating this artery from the tumor. And sometimes this can often be a challenge. Most often the artery is fused with the tumor capsule. And one more video. This separating dissection of ICA from tumor. And now you can see dissection by scissors, by sharp dissection. And here a couple of interesting case. This is not fortunate case. This case with complication, and even you can see before picture MRI before surgery and after surgery, and on post-op T1 plus contrast, the picture is good, but have a look. This T2 here, you can see this gel form. This is not tumor, but here and on DVI, you can see the spot of ischemia. And even if you save the nerve, the facial nerve, but damage the ICA, facial function will be impaired despite the preservation of the nerve. And we should keep in our mind. And a couple of such cases: huge tumor, not bad surgery, tumor removed totally, but the spot of ischemia on post-op MRI, and despite the preservation of the seventh nerve, unfortunately, patient has facial palsy. And one more, the same huge tumor, the complete removal, and the damage of branch of ICA. And you can see the spot of ischemia in the brainstem. Okay, after we were able to detach and isolate the ICA and separate from the tumor the lower nerves, immediately above the rostral root of the ninth nerve, we find a very important anatomical formation, hyroid plexus, which prolapsed from fourth ventricle through foramen Luschka, and this guide will lead us to root exit zone of seventh cranial nerve. And after I have visualized the nerve next to brainstem, I use a ball monopolar electrode for constant and immediate stimulation on a small electric current of the seventh nerve. It's very convenient device. And decreased amplitude of mimic muscle response by more than 50% is equivalent to braking function of seventh nerve. And the ball electrode, you can see here, could be pressed with a small pad or small catanoid or a piece of wet gel foam so that it does not move. And now, when we have both the peripheral nerve here and the central parts of the seventh nerve in our hands, it's easier for us to determine the direction of this cisternal part of the nerves, most stretched part of fascial. The nerve can stretch along the tumor capsule, forming the so-called fan. I don't know if my pronunciation, this word correct in English, and I insert this picture, this fan. And this fan can be large here, medium here, and small curvature. And I believe that there is never a lot of intra-op neuromonitoring, and I also use a bipolar probe already at the stage of removal of the upper medial and especially lateral parts of the tumor. This one more rule, only sharp resection with limited use of bipolar coagulation. And this part of the tumor, this part of the tumor is in the cisternal part of the nerve is most difficult to remove. And there are three basic patterns of position of seventh nerve. Anterior, when a nerve runs from the brainstem towards to meatus, obliquely, only diagonally, and this the easier to save the nerve. And second one, anterior upper. In this situation, the nerve creates a loop, and the wider of this loop depends on case from case. And the second and the third one, anterior inferior, then the loop of nerve locates on the ventral part and inferior part of tumor. In case of giant vestibular schwannoma surgery, the underlying brain parenchyma often softens and tends to bleed diffusely, even with very delicate manipulation. And when removing giant ventricular vestibular schwannomas, it's extremely difficult to preserve the arachnoid plane, especially next to brainstem, and sometimes we have to leave a small piece of tumor on the brainstem. And some intra-op pictures. This ideal seventh nerve. This nerve begins from brainstem and runs obliquely to meatus. But ideal result that does not always happen, such these intra-op pictures. And one short movie. I go on because my time is limited. So often you have to leave a very small piece of tumor on the nerve right next to pyramid. And we often talk about the degree of resection, but as a rule, the surgeon is wrong in assessing the remaining volume of the tumor. And the post-MRI, this contrast is not wrong. And this simple mathematical example demonstrates this fact to the fullest. And the surgeons always underestimate the size of residual tumor. This nature of surgery, nature of neurosurgery. Maximum attention should be paid seemingly poorly private issues, but which are great importance. For example, dentist vein preservation. We never know when a venous infection will occur, and it has a rather complex structure. I mean, dentist vein, but not at all necessary to memorize all the tributaries that form this vein. It's enough to know that vein has 3 groups of tributaries: low, middle, and upper. And one more nerve, which is rarely given attention, but which must be remembered and thought about, especially when removing ventral tumor fragments. This is a very fragile and tiny nerve, and it's better not to work with coagulation tool, coagulation pickup next to it. I mean, 6th nerve. And this nerve is extremely susceptible to manipulation. And again, we need to plan to remove the tumor totally. And here, on the example of particular case, I would like to demonstrate how a neurosurgeon, learns incorrectly. There is no doubt that, according to a number of authors, subtotal removal followed by radiation treatment very effectively controls tumor growth. But firstly, we remember that the class of evidence is low. And second, we never know in which case the tumor recurs and in which it doesn't. The predictors have not yet been determined. Nobody knows about predictors. And in my opinion, it always necessary to remove the tumor completely at the stage of pre-op planning. And this simple when surgeon decided to remove the tumor partially. The slide number 1. Neurosurgeon does not drill meatus. Neurosurgeon does not find 7th nerve. You are less oriented in the wound, and you get some problems with ICA, plexus of 4th ventricle, with central end of fascial. And further, violation of the principles of microsurgery, surgeon has a fake impression of the lightness of such surgery. And surgeons operate less and less, and arises a vicious circle. This one. And recently, just a couple of months ago, a wonderful neurosurgical meeting was held in Istanbul. And this picture you can see 4 gentlemen, the giants of modern neurosurgery. You know of all of them, Professor Kobayashi, Professor Matushima, Professor Ugurture, and Dr. Almevti. And this is my This is my last slide. Professor Kobayashi, more than 20 years ago, talk about all my lecture. My lecture, I delivered lecture a little bit confusingly, but this very simple 10 rules, and if we will follow all these rules, our result of surgery of vestibular schwannomas will be good. I thank you for your attention and for listening to me. Thank you very much.
Thank you very much, dear Professor Jamil. It was a very important lecture for all of us. And one more time, we have to know as a young neurosurgeon that neuroanatomy and particular preoperative examination will lead us to success. And getting knowledge from experienced people like you. Thank you. Anybody has questions or comments?
Thank you.
Thank you. Any comments from the audience? From moderators, maybe?
Questions, please.
Mm-hmm.
Don't be afraid. That's what the platform is for, interaction.
Yes.
Can I?
Yeah, of course, of course.
Yes,
Nagina.
of course, Dr. Simon.
It's really a great presentation. A lot of tips and tricks you already mentioned here. I have a question. A number of steps that has been written in our book regarding the arachnoid dissection after debulking of the tumor. Still, I think for 15 steps from inferior to superior. So can you simplify, how can we, why should we do that? And how can we simplify these steps to avoid the a complication like neural injury?
If I understood your question, how to simplify technique or?
Yes, steps of tumor capsule dissection after debulking. A lot of steps like
Sharp dissection.
1, 2, 3,
I
4.
mentioned that more safe it is sharp dissection. I routinely use micro scissors, the curved tips, and I use the set of Janetta, just 3 or 4 micro dissectors. That's all. I never use it's very complex tools, but the main issue that before debulking, that is my humble opinion, most of neurosurgeons, they start from debulking the surgery, but I almost always I start from drilling of the meatus, because this is very important for me to get the landmark of normal anatomy. I think this is very important in all kinds of neurosurgery, in peripheral nerves, in brain surgery, in spine, everything. You need to find the landmark. This is very important. And after that, you can decrease in volume the tumor. But most of neurosurgeons, they start from debulking to shrinkage tumor, and after that they go on to meatus. But I was frankly that the second my opinion why I start from drilling, because when you are exhausted in 3 or 4 or 5 hours, you are too lazy to drill off this. To be sincerely, to be honest. Maybe this sounds strange, this is for scientific speech, but our meeting is not scientific speech. Our meeting to share your own experience, and I can share my experience.
Okay, thank you
Thank
for
you.
the
Thank you very much.
yes, Suman.
Not sure I
sir, I have one
replied to
question.
your question.
Yeah.
I'm not sure.
Uh, sir, I have a question.
Yes.
Sure.
Yeah. Sir, do you have any specific landmarks for drilling the posterior part of ISC? Do you follow the Tübingen's line?
Did you
I
understand?
use routine technique
Okay.
drilling of the posterior wall of meatus. Only 5 and 6 millimeters long weights and heads. That's all. This small
Okay.
piece of I use position park bench position, and my angle of attack from posterior to anterior, and I can see without problem. I can see evaluate the state of posterior wall of meatus, and this is one of advantages such position. But many disadvantages of lying position. I have to use sucker constantly. I have to use sometimes bipolar because in case of semi-sitting position you don't need to use sucker because all the water and isotonic solution and blood can runs and can gas down from the wound. But the technique of drilling of posterior wall of meatus is not complex. Before this, I remove all catanoid from wound, and for protection of hemisphere, I use the thin plane of surgical wax, like protector.
Okay, sir. Thank you. Because in Indian settings, usually the vestibular schwannomas are usually very giant, and what happens is when we start drilling the posterior wall of internal auditory canal, we suddenly end up in the endolymphatic sac and
Very important
hearing
issue.
loss. Yes. Yes, so there is this paper from Malvar Campano saying about the Tübingen line. It is actually a very good landmark for the posterior most extent of drilling of ISC.
It's very importantly issue. You know anatomy of pyramid very well. This is very good. I'm trying don't to avoid the damage of endolymphatic sac, not to move on posteriorly and inferiorly. Only 5 and maximum
Correct,
6
sir.
millimeters
Yes,
to posterior.
maximum 6 to 7 mm. Correct, sir.
Yeah.
Yes, thank you.
Thank you. Thank you.
Okay, Nargiza?
Thank you. Nice discussion. And we are moving to our second presenter, speaker, Dr. Anton Ivanov. He's the second year neurosurgical resident from Federal Neurosurgical Center, Novosibirsk. Dr. Anton Ivanov graduated from Far East State Medical University. Originally, he is from Sakha Republic. Sakha City, Yakutia Republic. And today he will be talking about frontotemporal pterional approach, 1 layer and 2 layer scalp elevation techniques. Welcome, Dr. Anton. Please unmute yourself. Hello.
Yeah, just a second here. We haven't met you yet. We have to
Sorry, colleagues.
yeah, okay. Please introduce yourself.
Hello.
Hello, hello. Couple of seconds, please.
Yes, yes, we are waiting. Okay. Just share your screen.
Yeah.
Yes. Do you see my share screen?
Yes.
In process. Waiting. Okay, yes,
Okay.
now we can see. Mhm.
Hello, dear colleagues. I'm glad to present of my report. Let's talk about such a simple topic as a terminal approach, one layer and two layer scalp elevation technique. In what cases do we use this approach? Aneurysm or aneurysm of anterior circulation, basilar tip aneurysms, paracellular lesions, meningiomas involving the spinate wing and the anterior clinoid. The patient positioned supine with torso flexed slightly downward and knees slightly flexed to improve venous drainage. Soft gelatin roll placed under the ipsilateral short that can be used to reduce neck rotation. While the neck is extended to 15 degrees and the head is vertically rotated according to the surgical target. The head is fixed in a Mayfield three-point head holder. It rotated to the contralateral side, forming 15 degrees. The head is placed in a lateral position with the vertex slightly up 15 degrees to obtain a looking down surgical field to the infratemporal space. The ipsilateral zygoma is the highest point in the surgical field. One pin of the head holder should be placed on the ipsilateral side above the masted process. On the other arm, two pins are placed at the edge of the hairline on the contralateral side. The incision begins at the zygoma, 1 centimeter anterior to the tragus, to avoid damage to frontotemporal branch of facial nerve and frontal branch of superior temporal artery. The incision extends cephalad crossing the superficial temporal artery while coursing posterior to the hairline. The incision terminates at widow's peak. The base of the skin incision should be equal is high to avoid necrosis of the margin. Hemostatic lips rami are attached to the skin edge and galla to keep vascularity. The superficial temporal artery is preserved in every case, especially if the surgeon anticipates the potential for bypass. This is our operating room. The patient head is fixed is a Mayfield clamp. The skin incision line is marked from the zygoma to the hairline, and along the marked line, we begin hydro preparation with lidocaine or novocaine with adrenaline solution to the prevent bleeding upon incision. Let's talk about the anatomy of the temporoparietal region. The temporoparietal fascia lies under the skin and subcutaneous tissue over the temporal fossa. It's also known as a superficial temporal fascia. The temporoparietal fascia joins the orbicularis oculi and frontalis muscle anteriorly and the occipitalis muscle posteriorly. The layers from the skin to the cranium from superficial to deep in this region are as follows. Skin and subcutaneous skin, galla and superficial temporal fascia, loose areolar connective tissue, frontal branch of facial nerve, pericranium and deep temporal fascia, superficial and deep layers of deep temporal fascia, interfacial fat pad, and temporal muscle, pericranium, and cranium. The facial nerve exits the stylomastid foramen, enters the parotid gland, and runs anterior superiorly to cross the zygomatic arc to approximately 2 centimeters from the tragus and gives 3 main rami: the auricularis, frontalis, and orbicularis rami. The frontalis or middle rami innervates the frontalis muscle, which elevates the ipsilateral eyebrow. Superior to the fibrofatty layer, the frontal branch of facial nerve run just underneath the gallia aponeurotica, courses superficially to the loose areolar tissue and the suprafascial fat pad, and runs anterior-superiorly to innervate the frontalis muscle. In this area, the plane between the gallia and superficial temporal fascia is separated by loose areolar tissue without adhesion, which makes the elevation of the gallia and the loose areolar tissue from the superficial temporal fascia easy with minimal risk of the nerve injury. The two layers technique of skull flap creation for pteronal craniotomy gives better exposure of the pteron and sphenoid rim compared with the one-layer technique or myocutaneous flap. However, many studies reported that the two layers technique carried the risk of injury to the frontotemporal branch of the facial nerve. Several techniques have been proposed to protect facial nerve, such as subfacial, interfacial, and suprafacial or subgallial dissection. Subfacial dissection. The skin and the subcutaneous fat are separated from the tempoparietal fascia, and the tempoparietal fascia is dissected from the superficial temporal fascia in the loose areolar tissue plane, located between these two facial layers. The facial dissection begins by identifying the temporalis fascia. The temporalis fascia is incised to the muscle fibers, and the dissection is continued between the muscle and the temporalis fascia. The temporalis fascia split into superficial and deep layers, 2 centimeters before its insertion on the lateral orbital rim and zygomatic arc. By keeping the dissection in the tissue plane between the muscle fibers and the temporalis fascia, both fascial layers, superficial, superficial and deep temporalis fascia, are elevated together with the interfacial fat pad. Interfacial dissection. Dissection of the superficial temporal fascia is the same as with the subfacial method. As skin, gallial flap is formed in the same way. The dissection is continued on the deep temporal fascia below the interfacial fat pad. And the fat pad is elevated together with the superficial temporal fascia, thus exposing the lateral orbital rim. The final case step is suprastal dissection of the zygoma and lateral orbital rim that reveals the orbidozygomatic bar. Suprafacial dissection. The meticulous dissection of the suprafacial fat pad and the loose areolar tissue together with the scalp flap in the K to suprafacial dissection. The fiber fatty tissue, which is located above the anterior inferior 1/3 area on the temporalis muscle, should not be violated. In this step, the temporal fascia was not incised as performed in the interfacial and subfacial techniques, and the interfacial fat pad was not exposed as formed in the interfacial techniques. The superior half of the posterior aspects of the temporalis muscle was cut and extended along a temporalis line. Here we see that with the single flap techniques, the temporalis muscle does not sufficiently expose the lower parts of the temporal bone. So we have to trepanate a little higher. With the over technique, the muscle is pulled back, and we can do the trepanation lower or basilarly. There have been studies comparing different dissection options for the double flap technique. Each technique has its own indication. Suprafacial dissection results in significantly less incidence of abuse temporal hollowing compared with interfacial dissection. The indication for suprafacial dissection: when exposure of only the frontozygomatic process is required, frontal or pteronal approach, interfacial dissection is not necessary, and the suprafacial technique can be performed. Limitation for suprafacial dissection: the exposure of zygomatic arc for orbital-zygomatic osteotomy was another limitation of the suprafacial technique. How we do dissection? The use of rubber-banded fish hooks affixed dural ulna bar provides ample retraction of the muscle mass, and exposure is not hindered. Scalp incision with superficial temporal artery preservation was performed just above the root of the zygoma. The scalp flap was created just above the temporalis fascia using sharp dissection or Gauss dissection and through the loose areolar tissue, playing with the preservation of pericranium. Just above the temporal fascia, the loose areolar tissue and subgaleal superficial fat pad were dissected together with the scalp flap without separation. Dissection just beneath the superficial fat pad until the frontozygomatic process was reached, identified by palpation. The meticulous dissection of the superficial fat pad and the loose areolar tissue together with the scalp flap is this key superficial dissection. The temporalis muscle was then elevated from the scalp posteriorly inferiorly to maximally expose the pterium. The temporal fascia was cut along the frontozygomatic process to facilitate the posterior mobilization of the temporalis muscle, and the frontotemporal craniotomy was performed. The scalp flap was closed in the standard manner. As we can see, one layers technique, the incision is up to the periosteum, and the dissection line goes between the periosteum and the skull. All tissues, including skin, subcutaneous tissue, galla, temporoparietal fascia, temporal fascia, and muscle, are elevated. Thank you for attention.
And Dr. Anton, thank you very much for your nice presentation. Important landmarks, and even though we tend to think that pterional approach is one of the easiest approach, in fact, it is not. So unless you are so much comfortable in neuroanatomy and landmarks, you are not going to succeed. So thank you so much. Anybody has comments or maybe own experience in techniques from the audience?
Yes, I have. Thank you so much, dear Anton. Nice to meet you. And I have one question for you. Can you use hydro preparation along of the skin incision line in cases of bypass surgery? When you want to harvest STA?
When we perform bypass surgery, we not use a hydro preparation because we have a risk to the damage of STA. I think it's a lot of problem.
Okay, I understand you, but I think not only you have risk of damage of STA, but more risky for making a vasospasm of STA in these cases, because you can use adrenaline in
Constriction
solution.
of
Yes,
WASA.
yes.
Yeah. Okay.
Thank you so much.
Thank you.
Thank you for the comment. Anybody else who has questions? Maybe.
Yeah, I wanted to add 2-3 points.
Yes.
Yeah, from the skin incision itself, when you're planning a terional craniotomy, you should make sure that the both edges of the incision, if you draw a line from both edges of incision, keyhole should be at least 1 centimeter or at the midpoint of this line, so that you will not end up retracting a lot of skin, and the frontal branch of facial nerve will not be at risk, as he has said.
No. Is the risk too minimal? We have to minimal risk because frontal branch of facial nerve is located between superficial temporal fascia and deep temporal fascia.
Correct. I agree with your point. No, but I'm saying if the edges of your skin incision does not fall within this this region, what happens is when you retract, no, then it gets avulsed. And putting a key burr hole is very important. What I usually do is when I put a key burr hole, I see both the frontal dura, the base of the frontal dura, and also the orbital periorbita. And then I put a dissector into the skull base. I'll see the skull base, and exactly there I run my craniotomy. So that you will not end up drilling further bone for the frontal base, and you can avoid some cosmetic defect also.
Okay. We use first craniotomy. We perform it at the point which located as the superior temporal line or upper temporal line, and the Венечный шов.
Coronal suture. Coronal suture.
Yes. Coronal sutures. And we use trepanation as a perform. We can next to the craniotomy or frontal-basal direction. And the frontal-basal direction help us going to the anteriorly.
Okay. Dr. Abiram, any other question?
No, that's it.
Just a comment.
Jamil has a comment. Lisa?
Yes, of course.
Just a comment that it just seems that everything is easier, even for experienced neurosurgeons. But even conventional approaches require detailed anatomical knowledge. Great, thank you, Anton. Thank you. Especially thanks for great drawings, great pictures. Cool.
3D pictures were beautiful.
Thank you.
I like it. Own pictures, yeah. Cool.
Okay. We can move to our next speaker. So Dr. Andrei Kuzmin is not ready yet. So we would like to invite Dr. Rania Galyamova, MD.
He's here. Dr. Kuzmin is here.
Are you ready, Dr. Kuzmin?
Yes, of course. Yeah.
Okay, great. Then I will introduce you. Dr. Andrei Kuzmin, our next speaker, MD, PhD, head of the Department of Surgical Neuro-Oncology at Chelyabinsk Regional Center of Oncology, graduated from Ural State Medical University, and area of interest are glial tumors. So today, Dr. Andrei will be talking about surgical management of high-grade gliomas.
Okay. Good evening, good day, good morning, John. Dear colleagues, dear organizers of this channel, thank you for the invitation and for the possibility to present my talk in such channel, Neurosurgical TV. Since the beginning of 2023, our team works at the newly opened Department of Neuro-Oncology, which consists within the Center of Oncology. In the Center of Oncology, the patients are not only operated at our departments, but they receive further continuous necessary treatment modalities, including stereotactic radiosurgery, conventional radiotherapy, and chemotherapy. Talking about the high-grade gliomas, we keep in mind grade 3 and 4 gliomas. In grade 3, we divide anaplastic astrocytoma, anaplastic oligoastrocytoma, and anaplastic ependymoma. Grade 4 are not only glioblastomas. According to the new classification WHO 221, diffuse astrocytomas with IDH wild type are also grade 4 gliomas. Treatment options. So far, there are only three approved sequential treatment modalities in our armamentarium. And the first one is surgery. The second one is radiation therapy with chemotherapy in combine, and further chemotherapy according to the STUP protocols. Since 2005, the only one approved protocol for curing these patients with high-grade gliomas to prolong life in patients with such diseases has been used all over the world. This protocol was firstly published in the New England Journal of Medicine by Roger Stuck, and it was approval for life survival within 2 years. Since the initial diagnosis. Nowadays, surgical treatment is the initial treatment, and it's the treatment of choice for most of the patients as a first stage. Our goal of surgery is maximal resection if it is amenable. If it's not amenable, we use biopsy as the option to diagnose the disease and to transfer the patient to other treatment modalities, such as radiation therapy, to oncology, such as radiation therapy and chemotherapy. The first step and the first stage of treatment modality is surgery, and surgery should be done as maximal as possible. And the first resection, the first initial resection, it matters. The extent of radical resection depends. The life expectancy of the patient depends on the extent of radical resection. But we have the balance between the maximal safety and the maximal radicality. Because if we are too radical, we could damage the patient, and the patient could gain new postoperative deficit, and it worsens the prognosis for the patient. The goal of surgery is evident: to provide a longer life survival and to provide longer progression-free survival. But it leads to if our goal is only radical resection, it could lead to worse outcomes, either neurologic or not only neurologic. If it is if there are elderly patients, we could gain other somatic morbidity. What is the armamentarium for achieving this goal? In our armamentarium, we have certain tools to find the balance between the extent of resection and the safety for the patient. And there are a lot of, nowadays, not many, but a certain number of armamentarium we could use. And first of all, and Professor Jamil Zaev and Dr. Ivanov told that excellent knowledge of neuroanatomy is the first step. And applied knowledge of neuroanatomy and vascular architectonics is the first step. What we should begin our thoughts about the patients. We actively use metabolic navigation, electromagnetic navigation, and ultrasonic navigation to provide the safety of the operation and the radicality. To provide only the safety of operation and the extent the radicality, we use intraoperative navigation almost in all cases. Metabolic navigation is very popular and widely used in surgery of high-grade gliomas. What we could find and why we use this navigation? Because this tool is in the surgery of high-grade gliomas is comparable to those results with the use of intraoperative MRI. But there are a few clinics who has such a very expensive device like intraoperative navigation. And with use of metabolic 5LA metabolic navigation, we could achieve the so-called total resection, MRI negative resection, in close to 65% of our surgery, and only in 65% of all of cases without 5LA usage, the surgeon could achieve such result as gross total resection, so-called gross total resection. We understand that there is no total resection in the surgery of high-grade gliomas. Some surgeons, Some surgeons could argue that they are confident and enough skillful to use 5LA with comparable results of resection in white color without any implementation of metabolic navigation. I don't think it's a good decision. It's a good decision. Here is the picture of the tumor in white color, and it looks not like a typical tumor. It may be brain edema or even a normal tissue, even of white matter. But when we switch the 5LA filter, everybody could definitely say that it is a tumor, and if it is possible, and it could be possible, we could find it, we could delete it without any circumstances. Here is another example of non-evident tumor tissue under the white color microscope vision, which becomes evident that this is a tumor by implementing the filter with 5LA. To provide the safety of intact zones of the brain tissue, subcortical structures during the tumor resection, we widely use intraoperative neuromonitoring. We use general transcranial stimulation and local stimulation, preferably with monopolar probes, such as Rabe's probe, such as Rabe suction tube, and monopolar wire, which is connected with the ordinary suction tube, or even ultrasonic aspiration. Actually, neuromonitoring provides not only the safety of resection, but it spreads the borders of safe resection of the tumor, because we are more confident, we become more bold to remove more tumor, and very often it is very cool and even impossible to do without intraoperative neuromonitoring. In next series of pictures, I want to show you the results of the tumor resection with the combination of all tools which we use, and without which I'm sure we couldn't achieve such radicality in our surgery. There are T1 weighted scans with contrast enhancement, and we perform post-operative MRI scans to all the patients in less than 24 hours after surgery. All the presenting patients were without newly diagnosed post-operative deficits. However, we didn't check the fields of vision, the visual fields, when we operate temporal tumors in temporal region after surgery, and these patients are performed by ophthalmologists in a month after surgery. And this is the female patient in her 60s with glioblastoma multiforme, and she preoperatively has left-sided hemiparesis. After surgery, her hemiparesis slightly improved. Not in all cases, and even more in most of cases, we have temporal worsening of neurological deficits due to local vasospasm, maybe. But in the future time after surgery, in the closest time after surgery, most of the so-called temporal deficits is improving. Here is a lady with recurrent GBM, and first time we have resected this high-grade glioblastoma multiforme in 222, and after she administered to our department, we performed the excision of relapsed glioblastoma without any worsening in her health immediately postoperatively. Here are two weighted scans of the patient, T1 weighted scans of the patients preoperatively and immediately postoperatively. We could see in postoperative scans, we could see margins of hemosiderin enhancement. It's not tumor remnants, but hemosiderin would look like contrast enhanced tumors. The patients had compliance before surgery. She had compliance of visual field deficiency, but after surgery we couldn't check her vision acuity. Nowadays she is achieving adjuvant radiation and chemotherapy by STUP protocol. Here is another case of this is the patient. This was the patient. This is the patient of. He actually is a physician oncologist, and the first complaint was seizures. After performing MRI, we took him to the operative theater, to the operation, and you can see the result. And I think I'm sure that we couldn't achieve such results without such radicality, without use of 5LA, and such kind of safety without implementing the intraoperative neomonitoring. In next picture, it's not picture. Next movie, I want to show you, and you can watch the evident visual presence of tumor and the tumor enhancing by 5LA, and it's very evident, and you can see it's easy, and it is really easy to remove the main part of the tumor, and there is no question to do this. But next movie demonstrates this is white color microscopic vision, and it's very difficult to determine either this brain tissue remnants brain, either this brain tissue or tumor or brain edema or remnant of the tumor. And we see that this is remnant of the tumor. This patient has primary tumor, and this is not the scar because it is primary malignant glioma, and without such technique like metabolic navigation, it is very actually, at least for me, it is impossible to remove all the tumor radically only by my trust and by using my knowledge. Another underestimated, but for me very evident tool for navigation and for determining the location of the tumor is ultrasonic navigation, so-called dynamic navigation. In the microscopic view, we couldn't determine the tumor, and even neuronavigation during too many circumstances, such as brain shift, such as problems with the hardware of neuronavigation, we couldn't determine the real bodies of the tumor. But by using very light and very conventional device like ultrasonic navigation, we could very definitely determine the tumor, and after the tumor excision, we could check the tumor excision also by this ultrasonic device. In conclusion, I would like to say you that high-grade gliomas are still non-curable disease, and in more than 40 years, there is no way, and there is no any findings to cure this patient. And this is not the surgical or radiological or oncological disease. It's biological disease, and I think we have the patient have the hope to find the curative techniques of this disease in genetics, in biological, molecular biological issues, but not in surgery. But still now, so far, surgery remains the first stage and the main stage of the treatment high-grade gliomas, and it prolongs the lives of the patients, but not as we want and as patients want and hope, and their relatives. And collaborative work, teamwork, I think would be the key for solving this problem. Here is our team of neurosurgeons and neurophysiologists. Thank you so much.
Thank you very much, Dr. Andrei,
Thank you.
for the perfect presentation and so many things that should be noted. And we have to consider glial tumors as still one of the difficult in cure and doing the surgery. I just want to give very small comment, like philosophical comment. There is a famous Australian neurosurgeon, Charlie Teo. Once I met him in India, and he was giving a lecture, and he said that each and every tumor has its own shape, color, and sound. That's why it's very important when during the surgery, operation room has to be completely silent. There is no talk, there is no music, because once you are experienced, apart from neuroanatomy, you will understand how the tumor, talk to you and how it comes under your suction and under your other instruments. So thank you very much. Any questions or comments? Yes, Professor Jamil, please.
Thank you very much, Andrei. Nice presentation. I congratulate you on your start. I know you recently started your activity in your facility.
Thank you, Jamil Akadevich. Thank you so much.
Okay, and glioma surgery is a bitter bread of neurosurgeons. But how many cases did you perform in 6 or 5 months when you had started your activity? I mean the glioma cases.
Glioma surgery. Actually, we performed more than 300 cases. I think a lot of, I think 1/3 is metastatic diseases, 1/3 is glioma surgery. I think it's close to 100.
100.
Close,
and
close.
all of them are able to stay in your facility for adjuvant therapy?
No.
All these patients?
No. Before the charging, before we recharge the patient, before and after the surgery, before surgery and after, before we recharge the patient, we perform tumor boards with oncologists, with chemotherapists, and with radiation therapists, and sometimes with pathologists. And we, after that, we determine the schemes if it is a relapsed disease and if it is a recurrent tumor, and there is no, and it at least within 1 year, and there is no possibility to do radiation therapy. Chemotherapist administers the treatment modality to this patient. I think second tier, because the patients did the first year before. And if it is a primary tumor, they in 4 weeks they go to Department of Radiation Therapy and perform radiation therapy and chemotherapy. It's continuously.
Thank you.
Yeah.
Thank you.
And tumor boards are done in our department just before and after surgery with chemotherapists and radiation therapists.
Thanks.
Thank you. We have one more question from Dr. Agadadash Ravshanovich.
Hello,
Good
nice presentation, Dr. Andrei Kuzmin. I have two questions. How many hours before surgery to give patient 5 hours? And second question, do you always use metabolic navigation it for high-grade glioma? For example, the tumor insular and growth to deep brain. This situation, do you use metabolic navigation?
Okay. Thank you so much for your two questions. The first question, we gave 5 hours to patients at 6 or 5 a.m. and the operation starts at 9 a.m. Prior 3 hours before the incision. Prior 3 hours before the incision, and in the instruction there is noted that the patient should administer 4 hours prior surgery. In my previous institution, we began surgery slightly later, and we gave the 5 LA in 5 and 6 a.m. and it is like prior 4 hours before surgery. It was exactly like prior 4 hours before surgery. Now we gave 5 LA prior 3 hours before surgery. Concerning your second question, when we have 5 LA, but it not always, but almost all the time we have 5 LA. We give this medicine to almost all patients, including to almost all patients with high-grade gliomas. We suppose by MRI, even with insular tumors with insular regions, and we strictly use intraoperative neuromonitoring not to damage the insular region, but I understand it's sometimes it's very challenging because it's not about it's not about white matter, it's about perforating arteries. But we administer 5 LA to patients with insular gliomas, high-grade gliomas too. But in more than half cases, there are low-grade.
Okay.
Thank you. We have one more question from Dr. Abdullah Al-Ziral Husseini. Please, you can ask your question. You are unmuted.
Yeah, thank you for your presentation. It was so great with knowledge. I have one question. As we know, the gliomas are growing deeply in white matter and infiltrate between the axons of it. So we don't resect it totally. In this case, it's depending on the tract mostly which affected, or here just to decrease the intracranial pressure. This is the first question. The second question, how much the percentage of the tumor we have to remove if it is close to the basal ganglion?
I didn't get the first question, but the second question is the answer to the second question is that we use a monopolar probe, and if we achieving 1 millimeter signal, 1 or 2 millimeters signal to basal ganglia, we stop. If we are in 5 millimeters, we still working until 1 or 2 millimeters. This answer for your second question?
Yeah, of course.
Could you repeat the first one?
Yeah, of course. About the second question, this is what I was looking for. And about the first question, I meant it. If the tumor, it was infiltrated between the axons. So our resection, it's depend on which kind of axon, or here we have just to decrease the intracranial pressure.
Axon. What kind of axon?
such as what I meant, it's corticospinal tract or other tracts.
Yeah, we raise intracranial pressure into our meaning intracranial, and we raise intracranial pressure by raising the arterial pressure. Our meaning arterial pressure should be close to 90 millimeters by.
Dr. Andrei, I think the question is what should be the strategy in resection of tumor when it get involved into the axons? Should it be just
axons, yellow zones, axons.
Decrease in order to decrease the edema and midline shift, or we have to go up to axons? Am I right?
We stop.
Yeah, of course.
Yes. Mm-hmm.
If the tumor is in tracts, is within tracts, we stop.
Okay.
Okay, thank you for that.
We stop and we raise our perfusion pressure by raising our median arterial pressure, and we widely use papaverine solution.
Okay, thanks, Dr. Andrei. I got you.
Great. Where are you from, Abdullah?
From Palestine, but I'm doing my PhD in Russia, in Novosibirsk.
Great. Thank you. Okay. Any other questions or comments?
Yeah,
there are two questions from
Dr. Andrei.
Yes, thank you so much. Andrei, very nice to see you. Many times no see. I have two small questions for you. First of all, do you use only 5-ALA for metabolic navigation or sometimes use fluorescein? This is my first question. And the second question about your experience with awake surgery, for example, in cases of localization of the tumor in speech zone.
Okay, thank you, Andrei, for your questions. We don't use fluorescein. We use only 5-ALA. And the second question, the second question, we don't
about the awake surgery.
Yeah, we don't actually. I think not many people, even a few people, perform awake surgery in case of high-grade gliomas, and we don't perform surgery with high-grade gliomas, and even more nowadays, at least now, we don't perform it with low-grade gliomas. But I think we will not perform the surgery. We wouldn't perform the surgery with awaken the patient with high-grade gliomas, because I think it's another type of surgery.
Yes, understand.
Low-grade gliomas.
Thank you so much.
We have
I have
yes.
two more questions. Only removing high-grade gliomas. Yes, of course, because it's the predictor. 5-ALA is the predictor of protoporphyrin, and it is concentrates only in high-grade, only in malignant tumors, high-grade 3 and 4, and even in and there is no any need to use it for low-grade gliomas, and we don't use 5-ALA when we remove metastasis.
Thank you. One more question. Yes, thank you so much. So I think we can move to our last speaker for today, Dr. Rania Galyamova, MD, consultant neurosurgeon of Chelyabinsk Regional Clinical and Nuclear Medicine, graduated from South Ural Medical University, and residency was done in Federal Neurosurgical Center in Novosibirsk. Dr. Rania is the student of Dr. Andrei Kuzmin, and today Dr. Rania will be talking about treatment tactics for recurrent glioblastoma, clinical case, and literature review. Please welcome.
Can you hear me?
Yes, we can hear you. You can share your
screen. Thank you. 1 second, please. It's okay?
It is okay.
Not yet.
You
Not
can do
yet.
presentation mode.
No, it's not in presentation mode.
Which mode it is?
Sorry. Thanks.
Could you explain where to go, Nargiza? It's at the bottom. It's at the bottom, right, Nargiza?
Yes, yes. Там, где плюс-минус в нижнем правом углу, можно нажать на презентацию.
Yeah, it's one of those 4 icons at the bottom.
Так видно?
Так видно, но нам нужно...
At the bottom,
Yeah, you
внизу,
got it,
внизу.
you got it, you got
It's
it.
okay,
Perfect.
it's okay.
Perfect.
Sorry.
Sorry.
Okay.
Can you see my presentation?
Yes. Yes.
Oh, thank you. Thank you so much. Many thanks for Nargiza and Dr. John for the opportunity to speak. And I'm very glad to see so many familiar faces. And hello, everyone. Let's start. The topic of my presentation are the treatment tactics for recurrent glioblastomas. Glioblastoma remains the most common primary brain tumor with a median overall survival of 40 months. Maximal safe surgery followed by adjuvant chemoradiotherapy has remained the standard treatment for glioblastoma, but recurrence is an inevitable event in the natural history of GBM with most patients experience it after 6-9 months of primary treatment. There is no standard approach to the treatment of patients with recurrent malignant gliomas. Treatment options include repeat surgery, systemic chemotherapy, re-irradiation, and palliative therapy, palliative surgery, and palliative therapy. Indications for surgery should be discussed multidisciplinarity. I will give several examples of the most recent articles on the treatment of recurrent glioblastomas, tell you the treatment tactics, what we used, and tell about one interesting clinical case, and try to formulate indication for repeated surgery. This article reviews the result of various studies that evaluated the effectiveness of various forms of treatment for recurrent glioblastoma. According to the authors, surgery is the one most valuable tools in the treatment of recurrent glioblastoma, allowing control of symptoms and addition to it impact on survival control. Which patients were candidates for re-irradiation, non-candidates for surgery, tumors in eloquent, unresectable areas, Karnofsky performance scale more than 50, and 6-12 months since the first irradiation, young patients less than 50 years, good performance status, recurrence outside the previous irradiation field, small and localized, and in areas of lovely sensitivity to radiation. But with repeat radiation therapy, the risk of developing radiation necrosis increases. Combination treatment has also been described. The use of bevacizumab in combination with radiotherapy has resulted in improvement in progression-free survival, but no benefit in overall survival. Regarding systemic therapy, several options could be considered in the treatment of recurrent glioblastoma. All of them are considered palliative and none have been proven to be superior to another. Therefore, the choice among the therapies will be individualized based on tumor and patient characteristics. The following article states that one recurrence is detected. There is no standard treatment, but stereotactic radiation therapy is the preferred alternative based on their study in a sample of 59 patients. The authors conclude the stereotactic radiotherapy may have a favorable prognostic impact on survival in patients with a tumor size less than 2 centimeters. In our clinic, the scheme present on the slide is used to treat recurrent glioblastomas. If multiply lesions are detected on MRI, patients with a low Karnofsky status are treated with symptomatic therapy or palliative surgery. For single lesions on MRI, resection or radiotherapy is performed is possible, followed by radiation or systemic therapy. If the lesion is unresectable, repeat radiation or systemic therapy is performed. I would like to present you a clinical case from a recent practice. It's a patient, a female, 71 years ago patient, complained of an episode of falling without consciousness, which arose due to severe weakness in the limbs, uneasiness of gait, and speech impairment. Upon further examination, an MRI of the brain revealed an intracerebral tumor of the right temporal lobe. She was consulted by a neurosurgeon and planned surgical treatment was recommended. In our clinic, in order to maximize the preservation of neurological functions, was performed subtotal tumor removal. This slide shows an MRI study the next day after surgical treatment. You can observe signs of residual tumor along the contours of the resection cavity. In the postoperative period, she was discharged for outpatient treatment in satisfactory conditions. Karnofsky index at the time of discharge was more than 70 points. The pathogistological report revealed glioblastoma. Taking into account the age, radiation therapy was not prescribed in the postoperative period, despite the presence of residual tumor tissue. 6 courses of systemic therapy with temozolomide were prescribed. 2 months after surgical treatment, the patient underwent an MRI of the brain, and continued growth of the tumor was revealed. The result of the MRI were discussed with the patient at a consilium, and decision was made to undergo a second operation. At the time of examination, the patient has completed 2 courses of chemotherapy with temozolomide. At the time of admission to the clinic, the Karnofsky index was 90 points. The patient was bothered by periodic headaches, neurological status without features. It was decided to repeat the MRI examination. A control MRI study revealed a decrease in pathological tissue, and the therapeutic pathomorphosis was described. The patient was discussed at a consilium, again, consists of neurosurgeon, radiotherapist, and chemotherapist. Given the lack of data for tumor recurrence, surgical treatment was not indicated. It is recommended to continue system chemotherapy to complete the full course. The patient was discharged with recommendation. Taking into account all the above, I want to try to formulate indication for reoperation for recurrent glioblastoma. Presence of neurosurgical deficits or complaints due to the lesion. Conclusion of a control MRI study no earlier than 3 months, ideally in 6 months after surgical treatment. Lesion larger than 3 centimeters in the presence of a pathological focus in patients with suspect relapse of glioblastoma who received radiation therapy after surgery. Recommend PET positron emission tomography with methionine to include radiation necrosis. The presence of dislocation and mass effect due to the presence of a lesion. Karnofsky performance status more than 60, young age up to the 70 years old, resectable lesion area, and confidence in the effectiveness of repeat surgery. Thank you very much for your attention. If you have some questions, you can make. My English is not very good enough, так что
perfect, Dr. Anya. Thank you.
можно на русском. Спасибо.
English is great.
It's not about English, it's about giving important information and sharing your experience. So this is all we want.
Thank you.
And I'm glad that today we got around 40 participants. There was a time when we had 40 participants and from, I'm sure, more than maybe 8 or 9 countries. So that's great. The most important thing in Russian neurosurgery grant rounds is to show what we can do, to show how we treat, and again share experience, get knowledge from our international colleagues as well. So that is great. And I think today the webinar went really well.
That's
Even
awesome.
though there were small issues, but we overcome these issues.
Well, are there any questions for Renaya before we go? Any questions from the panelists?
Yes, Dr.
Jamil has one. Go ahead.
Professor Bennett, not question. I'd like to thank again you personally and Dr. Satova for nice meeting, and especially thanks you, Nargiza, for reminding me and all of us the words of distinguished Professor Charles Teo about necessity to keep silent in war. And
yes.
When tomorrow and maybe after tomorrow, I will tell of my colleagues, nurses in war, I can refer on words of distinguished professor. Is good words that any tumor has own soul, smell, sound, etc. It's true. It's really true. But brain surgeons, they don't listen to music. Mostly spine.
Yes.
Thank you again.
Okay, thank you everybody for coming. We really want to show Russia. We want to be part of you. We want to spread neurosurgery knowledge, irregardless of politics, religion. It's our religion is neurosurgery. That's all we want to talk about. And it's important, I think, to meet the people. We're people. We're not just watching videos. We're people interacting. Great discussions like today. And I'd like to thank Nargiza for organizing this thing. And I've got to run. I've got to go to an Indian webinar.
We are having another Indian webinar, so Dr. John has to leave. And so we are finishing for today. Next webinar is going to be 26th of November. And we are doing spinal section. Whoever wants to present, maybe your friends or colleague, please, you are most welcome. You can get my number, Gmail, and I will be glad to make a time.
Okay, do svidaniya.
Do svidaniya.
Thank you. Thank you so much.
Thank you so much.
Thank you for having us.
Thank you.